Welcome back to the channel. Today's topic is non-ST elevation acute coronary syndrome. We know that ischemic heart disease is broadly divided into two groups: chronic stable angina, that is CSA, and acute coronary syndrome, that is ACS. The common pathology belongs to the both is atheromatous plaque comprising with central lipid core with fibrous cap causing obstruction into the coronary artery lumen. Now, the pathology which differentiates acute coronary syndrome from chronic stable angina is development of the thrombus overlying the plaque due to plaque erosion or rupture. The size of the thrombus with degree of obstruction of the lumen decides the blood flow through the partially or totally blocked coronary artery. When the thrombus causing partial blockage of the lumen, there is no myocardial necrosis but ischemia develops. This is unstable angina. But when the block is near total or total occlusion, it will cause necrosis of the cardiac muscle and develop non-ST elevation ACS or ST elevation ACS. Near total occlusion when causing subendocardial infarction, that is non-ST elevation ACS with rise of cardiac marker, whereas the total occlusion causes transmural infarction with ST elevation acute coronary syndrome and rise of cardiac biomarker. Here we see the coronary artery lumen is partially blocked by the developing thrombus overlying the plaque. We see here the cardiac muscle is ischemic due to developing thrombus, but no question of necrosis. As a result, the cardiac biomarker will remain normal, but there is ST segment depression in ECG. Here we see the developing thrombus causing near complete obstruction of the coronary artery lumen. As a result, there is subendocardial infarction, ECG showing ST segment depression, and there will be rise of cardiac biomarker. As there is necrosis or infarction, there will be rise of cardiac biomarker. In this picture, we see the developing thrombus causing almost total occlusion of the coronary artery lumen. As a result, there is full thickness infarction, that is transmural infarction. As a result, there will be ST segment elevation here with elevated cardiac engine. So, acute coronary syndrome is divided into two main groups: ST elevation acute coronary syndrome, non-ST elevation acute coronary syndrome. Under non-ST elevation acute coronary syndrome, there are non-ST elevation myocardial infarction and unstable angina. The key difference between the unstable angina and non-ST elevation myocardial infarction is in unstable angina, there is no myocardial necrosis but only ischemia. Thus, troponin are normal. In non-ST elevation myocardial infarction, there is myocardial cell necrosis, thus there is rise of troponin. One thing we have to remember that STMI incidence is decreasing now due to widespread use of aspirin, statin and less smoking. Pathophysiology, there is imbalance between oxygen supply and demand due to plaque erosion or rupture. Clinical spectrum may be asymptomatic, may be chest pain, cardiogenic shock or sudden cardiac death. Typical angina, substernal chest pain radiating to arm, jaw, back, often with sweating or nausea. Anginal equivalent which occur in elderly, women and diabetics, patient present with dyspnea, epigastric pain, weakness or nausea. There is no chest pain. The characteristic of the chest pain in non-ST elevation acute coronary syndrome, it happens at rest or minimal exertion, lasts for more than 10 minutes, it is new in onset, chest pain this time occurring for last 2 weeks only, pain is worsening in severity and duration. Investigation ECG, there will be ST depression, T wave inversion or normal, but never elevated. Troponin elevated in NSTMI, normal in unstable angina. Regarding risk stratification, depending upon the TIMI risk score, age 65 or more, known coronary artery disease, 3 or more coronary artery disease risk factor, ST deviation more than 0.5 millimeter, 2 or more anginal episode in last 24 hours, use of aspirin in past 7 days, elevated troponin. Depending upon the 7 factors, their TB score 0 to 7. Higher the score, more chance of mortality, need aggressive management. Management overview goal, relieve ischemia, prevent infarction progression, reduce complication. Under 3 heading, we can manage anti-ischemic therapy, antiplatelet therapy, anticoagulation therapy. Under anti-ischemic therapy, there is nitrate, beta blocker, and calcium channel blocker. Under antiplatelet is aspirin, loading dose 150 to 325 milligram, then maintenance, and P2Y12 inhibitor like clopidogrel, prasugrel, and ticagrelor. Under anticoagulation, there is unfractionated heparin, low molecular weight heparin, like enoxaparin, fondaparinux, and bivalirudin. As a reperfusion therapy, we have to think only for the PCI. Fibrinolysis is not indicated in unstable angina and in STEMI. PCI is the only reperfusion therapy indicated for STEMI in selected cases. When the very high risk patient, there is shock, arrest, or refractory pain, immediate PCI is done. That is less than 2 hours. That is patient arrival and PCI intervention is less than 2 hours. In high risk, when hemodynamically unstable patient, recurrent ischemia, high TIMI score, we can do the early PCI, that is within 24 hours of arrival in the hospital. Long-term management, lifestyle, quit smoking, diet control, exercise, medication, dual antiplatelet therapy for 12 months, statin, AC inhibitor or ARB, beta blocker, risk factor control like control of blood pressure, diabetes and LDL should be less than 55 milligram per deciliter. Conclusion, non-ST elevation acute coronary syndrome includes unstable angina and STEMI. Remember the triad ECG, troponin, risk score. Fibrinolysis is not indicated in non-ST elevation acute coronary syndrome. Management and combination of anti-ischemic, antiplatelet, anticoagulant therapy, the cornerstone of treatment, and PCI only for selected cases. Thank you for watching.